Good evening, friends. Welcome back to this 47th episode of 4D, where we do our detailed discussion dialogues of Indian diabetes. It's a privilege for me to be here. I'm Dr. Sachin Mittal, your host for the show today, and consultant endocrinologist and diabetologist placed working in City Beautiful Chandigarh. This episode today, we are talking about a very, very important complication of diabetes, that is kidney disease, that is diabetic kidney disease, also called as diabetic nephropathy, also which eventually goes on to progress to chronic kidney disease and then end stage renal disease, etc. So today we will talk about the diabetes and the kidney relation. We'll talk about how we can diagnose it early. We can talk about how we can treat it early, how we can prevent its progression, and if it is already there, what are the best methods to take care of it? What are the best treatment options for it? Do we need any changes in terms of treatment protocol, not only the diabetes treatment protocol, but other treatment protocols? Are there any red flags we need to be concerned about at each stage, whether it is early stage, late stage? What can we do about it? And the why is all this important? This is all important because kidney disease, along with heart disease, is the foremost killer for any diabetes patients. Yes, the most common cause of mortality and morbidity in patients with diabetes is the cardiorenal diseases, right? That is, the cardiovascular system is affected because of diabetes. The kidney is affected because of diabetes, and we'll talk about them in the detail. And to talk about that, we have a wonderful learned endocrinologist today, Dr. Nivedita Kartika. Dr. Nivedita is a eminent endocrinologist, a DM in endocrinology, and is currently based in Madurai. She is the consultant endocrinologist at Anya Diabetes and Endocrine Center, Madurai. So, welcome, Dr. Nivedita, for the show. It's our pleasure to have you here with us, and we are looking forward to learning from your invaluable wisdom and gaining insights into how to help our patients with diabetes prevent kidney disease, how to have those patients with diabetes who already have kidney disease live better and live longer. So, our guest for tonight is Dr. Nivedita Kartika. She's a very learned individual and esteemed endocrinologist based in the beautiful temple city of Madurai. She has done her DM endocrinology from the prestigious Amrita Institute of Medical Sciences, Kochi. And it's our pleasure to have you here, Dr. Nivedita. Welcome to the show.
Thank you, sir. Thank you so much for your kind introduction. So I feel honored to be here today to discuss about this important topic, diabetes and CKD. So this is Dr. Nivedita Kartika from Madurai, consultant endocrinologist in Anya Endocrine and Diabetes Center practicing in Madurai. I've completed my DM endocrinology from Amrita Institute of Medical Sciences 2 years before, and now currently I'm practicing in Madurai. And my areas of interest, like if you look at it, is gestational diabetes and young onset diabetes, and also osteoporosis and menopausal endocrinology. So the topic for today, if we see diabetes and CKD, where are we standing now? So this is one area of importance because we all knew CKD in diabetes is something. Once it happens, it becomes the major challenge in managing diabetes, and also the progression of CKD, which when it happens, it also leads to cardiovascular mortality and morbidity. So CKD is a disease which we have to catch it early and prevent its progression so that we don't in complication state, which produces a significant healthcare burden. So we all knew in India, 1 in 11 adults is living with diabetes, and over 53% of the adults living with diabetes are undiagnosed. The number of people with diabetes in India is the second highest in the world, and 40 million adults in India have impaired glucose tolerance, which places them at high risk of developing type 2 diabetes. So we have 90 million adults living in India with diabetes, and 1 in 2 adults with diabetes are undiagnosed, and we have 747,000 deaths caused by diabetes in 2021. So now the rise in this number of people with diabetes is driven by a complex interplay of a lot of socioeconomic, demographic, environmental, and genetic factors. So if we look at CKD and diabetes, the increasing death rate because of CKD has been tremendously increasing over the past years. For example, India ranks fifth in rank causing death of CKD, and among the top 10 causes of death in Singapore, Greece, and Israel, because CKD is becoming a large burden in low and middle income countries, and the increasing death rate is significantly now we have stepped up by 41.5%. And the reasons for this are the racial minorities, one thing, elderly, individuals with hypertension, women, and individuals with diabetes mellitus. So these are the risk factors for CKD in diabetes. Next slide. Now, we all knew mortality is frequently present in diabetes and CKD, and the mortality rate for diabetic kidney disease is higher than the average mortality rates of all cancers. If we see the average mortality rates of all cancers is something around 50%, but in CKD, when the patient has albuminuria and impaired GFR, it is only 54.7%. I mean, it's 54.7%, which is as high and much more than the average mortality rate of a cancer. Now, coming to screening and diagnosis, CKD classification based scheme, the most important thing what we have to do is screening for albuminuria. That you do yearly. Like in a type 1 diabetes patient, if we pick up them at the initial stage, then we can do it after 5 years. And for type 2, we have to start at diagnosis, because we have not known when did the disease start. So for type 2 diabetes mellitus, it is at the point of diagnosis we have to do it. And when we have a positive result, we have to see whether we have any potential or spurious causes for this albuminuria. And if it is there, then repeat after eliminating that cause. And only persistent abnormalities leading to increase in albuminuria is a direct because of our chronic kidney disease. And we can do with spot urine albumin creatinine ratio and estimated GFR. So what defines CKD diagnosis is persistent urine albumin creatinine ratio of more than 30 milligram per gram and persistent eGFR of less than 60 ml per minute per 1.73 meters square. So these are the one thing. And these are the eGFR staging: G1, G2, G3A, G3B, G4, and G5. So eGFR more than 90 is G1, and 60 to 89 is G2. And G3A and G3B, we have 45 to 59 and 30 to 44. And stage G4 is less than 30 and G5 is less than 50. And now coming to albuminuria categories, if we see, A1 is something which is less than 30 milligram per gram, which we see most of the people with controlled hypertension, and 30 to 300 milligram per gram is moderately increased in A2, but for A3 is severely increased more than 300 milligram per gram. And so if we see here, when the eGFR is normal, but still if the patient has an albuminuria of more than 300 milligram per gram, then what we have to do is we have to treat and then refer. And the same thing happens for G2 and an albuminuria of more than 300 milligram per gram. And depending upon the G3A, G3B, if we have a reduction of less than 60 ml, we have to treat. And if the patient is having a G3 stage kidney disease and still an albuminuria of A2, then let it treat and refer. And for severe albuminuria, it's just treating and referring. And when we come to the stage G4, it's again treat and refer, and refer is like A3 and G4, they become very high risk, so he needs to be sent to nephrologist immediately. And for stage G5 with any degree of albuminuria, is they fall under very high risk and we have to treat them. So coming to this treatment strategies, early initiation of combination therapy, especially SGLT2 inhibitors plus a DPP4 FTC, suitable option for Indian type 2 patients for the following reason. One is they have a safer, rapid, and sustained glycemic control, improves both insulin resistance and beta cell function, and helps reduce the body weight and blood pressure, that is extra glycemic benefits, reduces pill burden, it's overall cost effective. And now coming to the improved management of diabetes and CKD, we have all the self-management programs, we have multidisciplinary care models, risk mitigation strategies, multidisciplinary education approach, and harmonized clinical practice guidelines. So now in medication therapy, we have DPP4 inhibitors, but they're not going to alter the course of the disease. We have SGLT2 inhibitors, and we have GLP-1 receptor agonist. So if we look at the SGLT2 inhibitors and kidney disease, they are both metabolic benefits, diuretic, natriuretic, and renal benefits. They restore the tubuloglomerular feedback, they reduces the interglomerular pressure, they reduces the albuminuria. So in early stages, when we have a normal physiology, we have a normal tubuloglomerular feedback. And now coming to the hyperfiltration in early stages of diabetic nephropathy, because we knew the increased sodium and glucose reabsorption in diabetes, it reduces the sodium delivery to the distal tubules, and because of this, the tubular afferent arteriole becomes vasodilated. We have elevated GFR, which is the hyperfiltration. But later, when we introduce the SGLT2 inhibitors, it increases the excretion of sodium and glucose, and then it normalizes the GFR by inducing afferent arterial constriction. So, to make the dose adjustment for eGFR, which we have precisely seen, and empagliflozin can be used up to a level of 20 ml per minute per meter square, and dapagliflozin up to 30, and even the canagliflozin up to 45. So that is one thing. And GLP-1 receptor agonist, we don't have any dose adjustments for dulaglutide, liraglutide, and semaglutide, and lixisenatide at a dose of 45. The use is not recommended, and less than that, there's no dose adjustment required. And DPP4 inhibitors, less than 30 ml, we can use 25, and at 45, we can use a maximum of 50 milligram per daily. And linagliptin is one thing which we don't require any dose requirements in C2. So coming to ADA, KDIGO consensus, all patients with type 1 diabetes or type 2 diabetes and CKD should be treated with a comprehensive plan outlined and agreed by a healthcare professional and the patient together to optimize nutrition, exercise, smoking cessation, and weight, upon which are laid evidence-based pharmacological therapies and preventing organ function and other therapies to attain the intermediate targets for glycemia, blood pressure, and lipids. A statin is recommended for all patients with type 1 diabetes or type 2 and CKD with moderate intensity for primary prevention and atherosclerotic cardiovascular disease, or high intensity for patients with known and some patients with multiple ASCVD risk factors. An AC inhibitor or angiotensin II receptor blocker is recommended for patients with type 1 or type 2 diabetes who have hypertension and albuminuria. So, SGLT2 inhibitor with proven kidney or cardiovascular benefit is recommended for patients with type 2 CKD and age of more than 20 ml per minute per meter square. Once initiated, the SGLT2 inhibitor can be continued at lower levels of eGFR. A GLP-1 receptor agonist with proven CV benefit is recommended for patients with type 2 and CKD who do not meet their individualized glycemic target with metformin or an SGLT2 inhibitors, and NSAIDs, non-steroidal mineralocorticoid receptor antagonists, with proven kidney and cardiovascular benefit is recommended for patients with more than 25 ml per meter square with normal serum potassium concentration and albumin despite the maximum tolerated dose of renal angiotensin system inhibitor. So with this, I conclude the topic. Thank you so much.
So today we're talking about diabetes and kidney disease, or diabetes and chronic kidney disease. We call it diabetes, kidney disease, diabetic nephropathy. We know that diabetes affects kidneys in a number of manner, and kidney disease, as we discussed earlier, is a number one killer along with heart disease for patients with diabetes mellitus, both type 1 and type 2 diabetes. So in this, first of all, Dr. Nivedita, we'd like to know from you, what is the prevalence of CKD in diabetes, and are there any demographic factors which are related with that?
Yes, sir. So coming to the prevalence of diabetes prevalence of CKD in diabetes in India, approximately they say almost 50%. Like some studies quote 30%, and some studies quote up to 60% in India, especially. So this is much higher when compared to the global prevalence. So that is what I should say in India, especially. And coming to the demographic factors, especially the South Asian ethnicity is one thing which we all know they are predisposed to diabetes. The same thing happens even for the CKD and other factors. No, especially in a country like our country, the developing countries where the screening methods are not as popular as we do in the Western setup. So the yearly screening, no, that is not happening. So we usually look at people when they're already on stage 4. So that is where we tend to see them. So this is might be attributable to the socioeconomic conditions, especially seen in India. No, that is one major reason which is increasing the prevalence of CKD in our community, especially. There are some genetic factors, no, like some of the
Right.
genetics. That is one thing which makes them more prevalent. So that is one aspect, and the ethnicity which I had mentioned. But according to me, if you say the early screening, the thing which is not happening is the one thing which is ultimately ending up to such high prevalence of diabetes, especially in India. So people should be
Right.
aware about the screening targets, the urine microalbumin and the EGFR calculation. That has to start from day one, especially for the type 2 diabetes people.
Right. So, friends, you look at these numbers. Dr. Nivedita talked about 50 to 60% patients, which means that almost, 1 in 2 patients at least is living with diabetes as well as kidney disease, which brings a very, very important point that, if so many number of people are coexistence, what are the coexisting with diabetes as well as CKD, what are the potential complications of that coexistence of diabetes, and how can we prevent them ideally, if not prevent them, if they already have it, how can we manage them? So Dr. Nivedita, your insights on that.
So first thing is, as we had rightly mentioned, the coexistence is very high. One thing is early screening, and the most common complication of CKD in diabetes, that ultimately leads them to cardiovascular morbidity. So diabetes is a disease which has a direct relationship with increase in the cardiovascular morbidity, and when the underlying CKD exists, then the risk is almost doubled or tripled, is what we should assume first. So the one thing is early screening them for cardiovascular risk factors, and most of the people, they advise antiplatelets, aspirin therapy to be started in a patient with diabetes and CKD, irrespective of the others, because CKD itself puts them under a very high risk for cardiovascular mortality and morbidity. And we all knew the major cause of death in a CKD patient in diabetes is not the end stage renal failure, but it is the cardiovascular death. So that one major
Right.
factor which we have to address them. So that is one thing. And apart from that, we have the other complications like CKD bone mineral disease, and that part which we have to take into account. So for me, if you say it's only the cardiovascular part which I would more focus and give an emphasis
Right.
about
Right.
it.
Right. Right.
And for
Right.
other managements, now we have all those drugs we have. So if we want to
Right.
prevent
Right.
CKD in the earlier stages, we did
We
have
can
only
use some
ACE
drugs.
inhibitors and angiotensin receptor blockers. But now with the advent of all the novel drugs which we have, especially the SGLT2 inhibitors, which has been a big breakthrough in the management of CKD and diabetes, which also reduces the cardiovascular morbidity and mortality. So what they say is any patient who are at high risk for this thing, though the primary prevention is not very high as compared to the secondary prevention, but it's better to initiate them on an SGLT2 inhibitor with proven renal and the CV benefit. Like we have all the three major things: empagliflozin,
Right,
dapagliflozin,
right,
and
right. We'll
betamethasone.
yes, yes.
Yes.
So that brings us to the next point. We'll talk about the drug therapy for diabetes in the upcoming things. But first, we'll like to learn from you more about other factors. One factor which has been very, very important in management of diabetes, and especially in management of coexistence of diabetes as well as CKD, is the blood pressure, right? One of the
Yes.
things which I remember is earliest said that one of the earliest manifestations of a diabetic nephropathy is the loss of nocturnal dip of blood pressure, which means
Yes.
that people have a lot of sometimes misinformation that with age it is this much should be my blood pressure, like 150 is okay for me, 140 90 is okay for me, 140 by 95 is okay for me, right? So if you have a patient with diabetes as well as CKD, right, does it have a different meaning in terms of blood pressure control? How does it impact the progression of CKD? What are the recommended blood pressure targets for patients with diabetes as well as CKD as per your
Sir, actually, the initial KDIGO guidelines, no, they had mentioned as 130 and 80, especially in diabetes patient with CKD. The 2012 KDI guidelines is what they have recommended. And for CKD patients, we usually tend to keep the systolic blood pressure to less than 130. Systolic and diastolic is actually less than 90. But later, there are some guidelines which had come out. They ignored the diastolic blood pressure, and they had said just keep the systolic blood pressure to less than 120, irrespective of the diastolic. They gave even a more stringent targets for the blood pressure thing. But I think now this systolic blood pressure of 130 and 80, like something less than that, I think it should be a ideal approach in our setting, just to.
Right, right. So that's a very important point to be mentioned to our patients, because a lot of patients think that sometimes they walk into the clinic, they think that I've just come from outside walking, my blood pressure is high, I'm stressed out because of XYZ reason, my blood pressure is high. I'm sitting in front of you, my blood pressure is high. I'm worried, anxious about you, my blood pressure is high. All of these are valid things. We can make a patient feel relaxed and recheck the blood pressure after some time, but if it is still continues to be high, we should tell them to strictly monitor that at home. Tell them that if you're in a relaxed environment also your blood pressure is on the higher side, don't let it go, don't let it remain like this, right? Because otherwise
Yes.
this high blood pressure will keep on killing your kidney, will keep on damaging the filtering apparatus of your kidney, will keep on lead to a progression of that kidney disease, and that's what will lead to the increase in the long term death. Not, let's not forget, the high blood pressure not only leads to a increase in the progression of kidney disease, but it is also very damaging for our heart. So it's important that the atherosclerotic complications as well as the heart failure complications are more increased, are exponentially actually, if your blood pressure, if the patient's blood pressure is on the higher side in the presence of diabetes. So it's important for us to tell the patient, like Dr. Nivedita beautifully mentioned, about the targets, what currently are the targets for patients with diabetes as well as CKD, and also that patients should be encouraged to proactively monitor them at home and maintain a record when they visit their doctor about it. So we come to the next important aspect. Before we go to the management of drugs with diabetes, we come to very, very important manifestation as to, what is this coexistence, this huge burden of diabetes and CKD? What does it lead to in terms of, the impact of on the healthcare cost, the impact on the resource utilization, and the cost effectiveness of different treatment approaches? And what are your thoughts about that, Dr. Nivedita?
So it's about the treatment approaches. Just
So overall, the coexistence of diabetes and CKD, how does it overall impact the healthcare cost, the resource utilization, and the cost effectiveness of different treatment approaches?
so, but from the cost point of view, if we look at the yearly screening methods, which if we are not advocating it properly, it is going to impose a significant healthcare burden, both in terms of the individual family and at the state and the country level. So screening yearly, and then because now we have a lot of drugs which can prevent the progression of CKD and which can prevent it from entering into the end stage renal failure and also the dialysis dependence and the renal transplantation. I think advocating a proper approach both in terms of dietary approach and the pharmacological therapy with the disease modifying drugs, and also like keeping them under controlled blood pressure, all these things, it reduces the healthcare burden in terms of monetary level. So that is one thing which we have to
Right. Right. Very, very important point. So what Dr. Nivedita is trying to say is that if you think about the long-term cost, the cost of not doing a screening in the long term is much more higher. The impact of economic burden, a single episode of hospitalization because of a cardiac event puts, is exponentially higher than the cost of 100 screenings done over a period of lifetime, right? So it just
yes,
goes back to
yeah,
the
yeah,
to
yes.
the to the age old adage, that is, prevention is better than cure. For that, we must remember that diabetes is a silent killer, CKD is a silent killer in the early stages, especially. The manifestations of the coexistence of both of them may not be there, right? So we need to be proactive, not reactive, when it comes to screening patients with diabetes for diabetic nephropathy, diabetic kidney disease, chronic kidney disease, etc. And it should be done on its own, right? Because not only that it impacts the healthcare cost, but also it impacts the efficacy and safety of commonly used diabetic medications. It leads to changes in regimen. So that brings me to another point, Dr. Nivedita. What kind of a medication regimen changes should be done in a patient with CKD and diabetes?
So CKD and diabetes, if we look at into the order, the sulfonylureas, the patient are already on sulfonylureas, especially the long-acting sulfonylureas, which are mostly excreted through kidneys. I think we have to be very cautious in prescribing them with the same dose which they have been taking it before, because the elimination time is reduced and their half-life is increased. They're more prone for hypoglycemia. So any patient with sulfonylureas, that is one thing. And if we look at the other drug, and any patient who are already on metformin, so anyone who eGFR is less than 45 ml per minute, we need not initiate metformin. But someone who's already on metformin, I think when the eGFR falls to of less than 45 ml per minute, I think it's better to reduce the dose to half of the dose which they've been already taking. And if we look at the other class of drugs, gliptin, so that is one thing commonly which you have been using, and we all know linagliptin has no dose contraindications for this. And the other gliptin, sitagliptin, when the EGFS is more than 45 ml per minute, I think we can give 50 milligram per day. When it becomes to less than 45 ml per minute, we can make it half the dose. So that is one thing taken into the gliptins account. And coming to SGLT2 inhibitors, and now we have very solid evidence from this ADA latest guidelines. No, they can be initiated even up to an EGFR of 20 ml per minute per meter square, because even up to that EGFR level, they have a proven benefit in reducing the mortality due to end stage renal disease. And dapagliflozin, I think up to 30 ml per minute per meter square, and canagliflozin, I think they'll have very much evidence to prove that they can be used without any hesitation regards
Right,
to
right.
SGLT2 inhibitors. And if the patient is already on insulin, I think their dosage also has to be like adjusted, and frequent SMBG has to be done when the patient is on insulin, because it's the same thing that applies to them, their risk of hypoglycemia.
So there are two aspects, as Dr. Nivedita beautifully pointed out, that there are certain medications which need modifications, which need dose reduction. Long-acting sulfonylureas we should be very careful about. Metformin, about half of the maximal dose. If the EGFR is between 30 to 45 ml per minute, which means that up to 1 gram you can use, or 1.2 grams you can use, but not more than that. And if the patient is not on metformin, then it is better not to initiate first time the metformin in such a patient at that point of time. And the EGFR falls less than 30, obviously metformin should be completely withdrawn from the patient's prescription. Sulfonylureas, if the patient needs it, then you can use, instead of long-acting, a short-acting sulfonylurea, which has been shown to have good amount of data in the variety of patients with chronic kidney disease, etc. But be mindful of the fact that any drug which is either an insulin or a secretagogue can lead the patient to a risk of hypoglycemia, and at that point of time we need to make sure that the patient is doing the self monitoring of blood glucose repeatedly at home. Patient is aware about what are the signs and symptoms of hypoglycemia and how to manage them. Sometimes many of those patients may have a coexisting autonomic neuropathy, as a result of which they may not have the awareness of signs and symptoms of hypoglycemia, and as a result of which it's important for us to again tell the patient to check the blood glucose readings properly, regularly, and sometimes not wait for a event to happen. And if something tends to be towards the lower side, the blood glucose tends to be in the hypoglycemic range, get in touch with the doctor, and he or she will take care of in terms of management of the diabetes in a better manner in situation of the coexisting kidney disease. But there are some of the situations which are like special populations, right? And these special
Yes,
populations are always special, whether we talk about pregnancy, whether we talk about elderly, whether we talk about children with diabetes and CKD. What are the challenges and how do we overcome those challenges in these special populations when you have a diabetes and chronic kidney disease coexisting in these populations?
so, especially in elderly patients, if you look at the same thing which you highlighted very beautifully, the risk of hypoglycemia, which we have to educate them to the patient and also to the bystanders, because we all know the gluconeogenesis part from the renal contribution is going to be less. And in elderly patients, that has to be focused on their management of their part. And the medicines such we had mentioned before, so the sulfonylureas and the insulin part, they have to be modified precisely to suit them. And also the nutrition part also has to be taken into account in elderly patients and CKD, because CKD already it is a protein energy malnutrition state. And if the patient is on drugs without paying a better attention to the nutrition, and I think the hypoglycemia risk is going to get increased in those patients.
Right, right. So, which brings us to probably the last question for tonight. That is, we have had some breakthroughs in terms of management of diabetes with CKD. And, if I look at a decade back to, when I started practicing endocrinology after finishing my DM, to, what currently the options in our armamentarium in terms of helping our patients with diabetes and kidney disease have gone up, right? And we have got
Yes,
more
sir.
options now. And there are some novel medications. Some of them are anti-diabetic, some of them are not anti-diabetic, but medications nevertheless, only in diabetic nephropathy as of now, which have been approved and which have been shown to have a additional advantage for patients with diabetes and kidney disease. So what is the impact of those novel anti-diabetic medications? I'm talking about the SGLT2 inhibitors, the GLP-1 receptor analogs, especially on renal outcomes when it comes to patients with diabetes and CKD.
Novel drugs, no, actually, they are very, very important in preventing and addressing the progression of the disease. So progression of CKD is one thing which was challenging, as you said, in the last 2 decades. But now we have drugs to prevent its progression. We had only AC inhibitors and angiotensin and receptor blockers like a decade ago, so which we used to initiate when there is an albuminuria in such patients. But now we have other classes of drugs. One is the SGLT2 inhibitors and GLP-1 analogs. So SGLT2 inhibitors, they prevent, they can be used in patients who has albuminuria or whose EGFR cutoffs, which we have seen before. So empagliflozin, even when someone has an EGFR of more than 20, I think we can be used. So these are the drugs which not only provides glycemic control benefits, like we have to say that in patients with CKD, the glycemic target has to be like very strict in preventing the progression. But these drugs, apart from preventing the complications, not just related to the diabetic control, but also in terms of their innate therapeutic effect. For example, SGLT2 inhibitors, they restore the tubuloglomerular feedback. So that is what the major mechanism of action which they say. So though at the level of EGFR of 20 ml per meter square, the efficacy of drug is not very high because these drugs act by excreting the glucose through the kidneys, but still innate, it's depending upon the acting upon the vasculature, the blood vessels, and at the cardiac benefit, they provide a very important mechanism. So they prevent the progression of albuminuria, prevent the progression to end stage renal failure and dialysis dependency, and also the renal transplantation. So most of the studies which we have, EMPA kidney, then DAPA glyphosine and renal outcome trials, and we have the credence trial, they have shown very good results in preventing the progression to end stage CKD. And also for GLP-1 analogs, still they are not at the first line management in diabetes with CKD, but for some patients who are having a contraindication to use SGLT2 inhibitors, to such patients we can use a GLP-1 analog which has a proven renal safety mechanism, especially dulaglutide and liraglutide. They don't require any dose adjustment here. And also for semaglutide, I think these are all the novel drugs which are available. And recently we have the other drug, finerenone, can also be used to prevent the progression of CKD.
Right. Thank you so much, Dr. Nivedita,
Yes,
for
sir.
your wonderful insights. And it has been pleasure having you on the show today, and wishing you all the very best for your